Hi everyone, and welcome to the AMCHP webinar, Measuring a Life Course Approach to MCH, the AMCHP Life Course Metrics Project and Final Set of Indicators. I'm Carolyn Stamfel, Senior Epidemiologist at AMCHP, and I will be your moderator for today. On behalf of AMCHP, we're delighted that you are joining us. We're very excited about our webinar today and to dialogue with this wonderful panel of speakers. Before I get to the specifics about our agenda and turn it over to our speakers, I do have a few housekeeping reminders. Audio is available through your computer, though if you're having technical difficulties with your audio, please do contact me via email at cstamfel@amchip.org or message our chairperson. We have reserved the last 15 minutes of the webinar for a question and answer period. We invite you to submit questions throughout the webinar by using the chat box at the lower left hand of your screen. Please address your questions to the chairperson and also be sure to include which presenter or presenters you are addressing your question to. Today's webinar will be recorded and the recording will be available on the AMCHP website at www.amchip.org/lifecourseindicators. Following this webinar today, you will receive a brief link to a survey, and we ask that you take a moment to please offer feedback, which will help inform our future webinar efforts. We are also encourage you to visit the AMCHP website to look at the resources referenced during today's webinar. And lastly, next week you will receive an additional email that will have the link for the full set of slides and the recorded webinar. So be sure to look out for that so you can share with your colleagues who may be interested in the information but were not able to attend today. To help us achieve today's objectives, we have a wonderful panel of presenters with extensive expertise and commitment to measuring a life course approach to MCH. Please note that due to the packed nature of our agenda and the many objectives we want to achieve today, we will not be presenting full bios of each speaker. Today's webinar has three main objectives. The objectives are to explain the growing need and momentum for standardized indicators to measure a life course approach to MCH, to describe and identify opportunities for MCH programs in implementing and using life course indicators in needs assessment, program and policy planning, monitoring and evaluation of MCH outcomes, or engaging and educating partners, and to determine how your MCH program may use the indicators to address emerging priorities. Our first speaker for today will be Dr. Bill Sappenfield, Professor and Chair in the Department of Community and Family Health and the Director of the Lawton and Rhea Childs Center for Healthy Mothers and Babies at the College of Public Health at the University of South Florida. He has served as AMCHP's facilitator for state team indicator selection for the past year, and he will share the background and process for indicator selection. Bill will be followed by Dr. J.C. Phillips, who is the Senior Epidemiologist and CDC MCH Epidemiology Assignee in the Division of Community Health Promotion at the Florida Department of Health. She will be sharing the experience of the Florida team and some of their planned next steps. We will then hear from Brenda Fink, who is the Director of the Division of Family and Community Health at the Michigan Department of Community Health. She will share the Michigan team experience and some of their other activities around life course. After the formal presentations, I have invited a Title V Director and Louisiana State Team member, Amy Zapata, to share some reflections and dialogue with the panel. And now I'd like to turn it over to our colleague and friend, Dr. Bill Sappenfield.
Thank you, Carolyn. It's great to be able to join you all today. I'm the volunteer of a fantastic team. Peggy Callahan, Carolyn Stanfield, and Andrea Cornell have done a huge amount of work with other AMCHP staff to put all this together. And again, we want to thank the expert panel and the state teams who really did all the works. And this is great to get a chance to share what we've been focusing on for such a short period of time. My presentation has four goals. I'm going to share the process of development of the life course measures. We're going to review the summary final indicators selected. We're going to discuss briefly some of the public feedback, but give you more a chance to ask your questions, and then share some of the immediate project next steps. Life course has been just a growing focus for MCH and MCH public health agencies. In 2010, Amy Feinstein and Bill Kochuk put out a concept paper for the Bureau on life course and the need to focus our efforts in a more life course perspective. In 2012, the Bureau in its SSDI grant application to state public health agencies asked that states report their effort on life course metrics. That was sort of the first time that the Bureau had identified that this was an effort that states should be working on. And based off of that request, states got together with AMCHP to put together a proposal so that we could come up with some state-recommended life course measures so that all of us could be considering the same metrics. We were very lucky that Kellogg in 2012 gave funding to AMCHP to actually put this whole initiative together so that we can have a collective recommendation on recommendations. The purpose of the metrics process is to develop tools to help state MCH programs and their partners, especially partners at the community level, to emphasize life course health perspective through assessment of risk and capacity and services, some needs assessment process, planning process for programs, doing monitoring and evaluation of outcomes, and really trying to engage and educate partners, because you can't move a life course focus forward without bringing in others. And so when you ask a question, so when a final set of life course center exists, what will be the impact for the health of moms, kids, and families throughout your communities? Some of the responses from our state teams we got were, 1, support MCH priorities to improve health outcomes, integrate and coordinate care systems, eliminate racism, and move towards equity. Another said it would help state health departments come out of their silos and think outside the box to better design programs and interventions that impact the life course trajectories of mothers, children, and family. And that's really what we were trying to do through the life course indicators, is develop tools, indicators that state public health agencies could use to really help with planning and monitoring and moving in this direction. Our process started in phase 1. We pulled together a national panel to help frame what is life course, what are life course risk indicators, how should we develop them, and what are some of the potential criteria that we should use. And we really do thank all the experts who got together and shared their thoughts. And this was actually very helpful because we had wide perspectives, wide opinions, and trying to capture the strengths of these so that they could be used in the state selection process. From a life course perspective, we proposed from the experts the following definition or core principles of a life course approach. A life course approach is based on a theoretical model that takes into consideration the full spectrum of factors that impact an individual's health, not just one stage of life, but throughout all stages of life. Life course theory shines light on health and disease patterns, particularly health disparities across populations and over time. Life course theory also points to broad family, social, economic, and environmental factors as underlying causes of persistent inequalities in health for a wide range of diseases and conditions across population groups. We put this definition together, and it was very helpful because we frequently went back to make sure we knew what we were focusing on when we talked about life course. One of the other real pearls that came out of the expert panel group was a developmental framework. As we started to talk about indicators for the life course, we just weren't going to be interested in having indicators of risk or indicators that were outcome, but really identified the need for state public health agencies to also focus in on services that would help with risk reduction and health promotion, and also think about the capacity at a community and organizational level to address life course. That we really needed to have all of these to be able to assess what the issues were, what we were trying to do, what we needed to do, and how well we were doing it. After the expert panel convened, we had our meeting, and we had a knowledge transfer with state teams that were selected. We proposed indicators. We screened indicators. We wrote the indicators up. Then we finally selected indicators and went for public comment. And now I've reached the point that we're now releasing the final indicators in full form. In terms of selecting teams, we put out an application to all of the Title V agencies across the country. We had almost twice as many applications as we had slots for teams. We selected 7 teams: Florida, North Carolina, Nebraska, Iowa, Michigan, Louisiana, and Massachusetts. We were so pleased that they volunteered. And even though they thought they knew what they were getting into, I think they really realized 2 things. One, that this was a lot of work, but 2, there was a lot of value in collectively working through this process together. The state teams took the developmental framework that the expert panel came up with of risk, services, outcomes, and capacity, and then also put life stages across from the maternal and child health perspective. And so when we proposed out to suggest indicators, we actually suggest that they look across these life stages in these 4 areas to try to make sure we had the right indicators being considered. This was also submitted out to the expert panel and to the public at large, so that we requested input on the type of indicators and that should be considered for this recommended data set. The criteria that the state teams ultimately came to fell into 2 categories. One was a data set criteria. How available were the data at a state and local level? And what were the percentages of states that would actually have that data available to produce the indicators now? What was the quality data, the accuracy, the reliability, the consistency, and what was that like across all the different states? And then 3 was simplicity. 1 was simplicity in terms of how the measure was actually calculated, and the other was the simplicity of trying to explain that indicators to partners and others as you were trying to use that as a tool. On the life course side, we really wanted to make sure the indicators we're selecting were not just traditional MCH indicators, but indicators that would really help us to focus on a life course perspective. So we wanted to know the implications for equity, because equity was really one of our fundamental values from the life course perspective. How well did the indicator reflect and has implications for equity-related measures such as social, psychosocial, environmental conditions, poverty, disparity, and racism. We also asked public health impact. Was there really going to be, if you did address this indicator, would there really be a positive change as it related to policy and program? 3rd, the ability to leverage resources or realignment. How well would the indicator reflect program and services and policies that expanded beyond traditional MCH focus? Could we use it to recruit partners? Could we use it to recruit resources to expand the ownership of the issues? The 4th and 5th were 1, improve the health and wellness of all individuals and or their children, including an intergenerational health component. How will the indicator reflect the time and trajectory components of life course theory with an emphasis on the indicators that address critical and transitional periods throughout the whole lifespan? And consistent with the evidence base, how well did the indicator connect with the current understanding that we have of the science and the practice of life course health? So we used all these criteria. We used it at 2 stages. We used it, 1, to screen through the indicators, and then 2, we used this to help select the final set of recommended indicators. If you ask about what the selection process was like, we started out with 413 proposed indicators that should be considered by the state teams. Of that, we pared that list down to 104 that we wrote up in detail to make sure we understood the indicators and all the characteristics so that we could adequately score and then vote. And then of the 104, 59 were voted in by a supermajority of states. At least 5 of 7 states needed to say, this makes a good recommended life course indicator. In this process, there were a series of challenges, and we just wanted to highlight 6 of them. One of the challenges was data availability at the state and local level. Was it really there? For many of our core data sets, there are mandatory components, but sometimes they're optionals. And so how many states have it, and could they have it, or could they choose it? Was it really available? and we spent a lot of time going back and forth because our primary goal was we wanted life course measures that we could recommend right now that state public health agencies could use. Second, we had problems with the availability of non-traditional MCH data. As we went after available data, we had to go after the data that was already out there being collected and being reported, which makes it a challenge, especially if you're talking about something that's available across all 50 states. So many of the indicators that were suggested or considered that would be considered non-traditional were really attractive and had value, but it was hard to find available ways of trying to actually measure what was being suggested. Data quality and simplicity. A lot of the data was not as clean as we wanted, or didn't clearly reflect the way we wanted to, or got to be very, very complex, and we weren't sure how useful the indicator would ultimately be in terms of both estimating it and then using it. We had a lot of overlap with other measures, and so we've tried to minimize as much of the overlap as we could while covering the span of what was needed. Issues of root causes were highlighted by other measures. In other words, we might have 3 or 4 measures that might be related to the same issue, and figuring out which of the measures would be the right ones. And then the last was life course and life course research, and what are the most critical measures at those sensitive or critical time points is still being researched and still being explored. And so we really were challenged by what we have now versus what we wish we have and what might be coming in the future. Public comment. And the public comment on the second time really looked at, so these are the recommended measures, what is your feedback? We had some great changes on numerator and denominators, even potentially data sets that we changed based off of public feedback. We also looked at sort of as a confirmation process that most of the feedback was very positive with what was being selected, why it was being selected, and what was being included. And then on our website, we have a whole series of frequently asked questions about indicators, and the public comment really helped us identify what were those key questions that needed answers that people were asking and trying to make those answers available. In the final set, we mentioned that there were 59 indicators. We've lumped them into 12 descriptive categories. All 12 of them are here, and next to them are the number of actual indicators in each of the categories. We were not trying to have an equal number in each of the categories. We were more just trying to describe them in ways that they could be more easily used since there were so many. But it covers childhood experiences, community health policy, organizational measurement capacity, all the way to social capital. What we discovered, though, as we actually whittled it down to the final 59 recommended indicators, we did find that there's a lot of overlap between the recommended indicators and what's currently out there as indicators. And so we recognize that up front. We actually consider that potentially a strength because then it can be used in more than one location and then validate some of what we're including. We also recognize it's a weakness in the sense that we may not have been able to measure some of the new risk, outcome, services, or capacity that we really wish we would have had. 16 were our Title V measures that are recommended to states already. 8 were from the recommended core set of preconceptional health indicators, 36 from healthy people objectives. 6 were winnable battles by CDC. 14 were recognized chronic disease indicators. 9 were recognized by the National Quality Foundation. And then the United Health Rankings recognized 6 of them. To make it readily available, because the purpose of the recommendation is to have public health agents be able to use them in other community groups, we've now posted the full set of indicators on the AMCHP website. It came out in September to October. They're all there in full description of what the measure is, how to estimate the measure, and what are some of the strengths and weaknesses. We've also put all that into printable format for each of the measures so that when you want to know a lot about a measure, you can actually dig into the information that we had available in the selection process. We also this time came up with what we call our short list. We took the 59 indicators and asked our state teams to come up with those broadest measures that would cover the span of what our measures were that states should be considering. So if you went to a short list, what were they? And here they are broken out by risk and outcome and capacity systems. Thank you, and that brings us to the end. Again, this is the website that you should be able to go to and find out more of the information.
Great, thank you so much, Bill. And now I'd like to not waste any time and just turn it right over to Dr. J.C. Phillips. J.C.?
Thank you, Carolyn, and thank you all for joining us on today's call. Today I will be presenting Florida's perspective and experience with the Life Course Metrics project. As stated earlier, Florida was one of 7 participating state teams. Our team included contributors from the department's program and epidemiology staff who worked on various MCH issues such as infant, maternal, and reproductive health, chronic diseases, and children's medical services. Also included were community partners from local Healthy Start coalitions, consultants who brought clinical and disability perspectives to the table, as well as a few partners from state universities. Thanks to Drs. Bill Sappenfield and Ike Eberstein, we were able to recruit 10 graduate students from Florida State University and the University of South Florida. These students volunteered to lead writing narratives for several of our assigned indicators. Volunteers and staff were assigned at least one of 3 roles. Primary authors were responsible for thoroughly reviewing and summarizing the literature on their assigned indicator or indicators. Secondary authors reviewed the work of the primary author, checked for errors in content or formatting, and added information relative to the life course perspective. The editor reviewed and edited the collaborative work of the primary and secondary authors. Florida and the other participating states experienced some challenges that were addressed by using various effective strategies. For example, to address our need to find enough writers and writing resources, DOH staff members, 2 Healthy Start Coalition representatives, and 10 graduate students assumed roles as primary and/or secondary authors for at least one of the assigned indicators. Typically, DOH staff have very limited access to peer-reviewed articles online. However, graduate students and I were able to address that need. Also, a Life Course Metrics project of this magnitude has never been done, and thus there were very few resources available for use. One resource used was the Preconception Health Indicator Project, and for additional feedback, AMCHP encouraged writers to contact subject matter experts for assistance. There were times when we did not grasp or internalize some of the goals and concepts immediately, and this actually goes hand in hand with what Bill said earlier about helping states to think outside the box. For example, during the infant stages of the project, our team had some difficulty embracing the expectation that we were to consider indicators that were not examined on a day-to-day basis for MCH programmatic or EPI work. Also, addressing some of the life course criteria elements proved to be a bit challenging, such as fully understanding the criteria implications for equity and the clear distinction between health inequity and health disparity. Health disparities, as we all know, are population-specific differences in the presence of disease, health outcomes, or health access, whereas health inequity captures the sense of unfairness or whether something is unjust. For this project, we followed the advice of some experts to count every health disparity as a health inequity until proven otherwise. The last major challenge was having to do all the required work within a limited time frame. Florida intends on using the indicator narratives to enhance our efforts in completing needs assessments for our Title V and Title X competitive grant applications. We expect that the narratives will serve as a guide to help us broaden our current base of collaborators or leverage partnerships for Florida's focused areas. The narratives will also assist us by knowing which data sets we could use to analyze certain indicators that may not be commonly used, and also by knowing national prevalence estimates and programmatic efforts to which we can compare to our state. We also plan on creating a life course indicator report for indicators that can be examined in our state in order to set benchmarks that will assist programs. We have intentions of conducting life course related analyses using Florida's maternally linked file, which links different births to the same mother using data from birth certificates, infant death certificates, hospital discharge records, and other sources. Of all final life course indicators, I am sure that we'll be doing a lot in the future to address obesity from a life course perspective, given that adult and childhood obesity are major priorities for the Florida Department of Health, as demonstrated by the establishment of our Healthiest Weight Florida initiative. This slide shows the homepage of Florida's Healthiest Weight Initiative website. Under the leadership of State Surgeon General Dr. John Armstrong, the department launched the Healthiest Weight Florida initiative, which is a public-private collaboration bringing together state agencies, not-for-profit organizations, businesses, and entire communities to help Florida's children and adults make consistent, informed choices about healthy eating and active living. Although the Healthiest Weight Florida initiative was not born from the Life Course Metrics project, I found that it still encompasses many key life course principles and concepts that will ultimately help to make substantial reductions in the prevalence of obesity in our state. And for the remainder of this presentation, I will talk about how objectives and activities of this initiative overlap with concepts of the Life Course Metrics project. I just think that it can serve as possibly a great example of how to use a multi-pronged approach with life course elements to tackle a major public health issue such as obesity. The Healthiest Weight Florida initiative has several objectives for reducing obesity that fall under different time points along the lifespan, from early to later life. Through the initiative, the department is building collaborations and providing assistance to counties, community groups, and other partners to implement programs that focus on increasing the initiation, duration, and exclusivity of breastfeeding, promoting improved nutrition and physical activity in early care and education, and increasing physical activity for students during the school day and after school programs. Other objectives that cover multiple periods along the lifespan include, but are not limited to, increasing physical activity by improving the built environment in communities, increasing access to high-quality, affordable foods in communities, and promoting weight counseling in clinical settings. The current activities associated with the Healthiest Weight Florida initiative fall under 5 of the 12 life course thematic categories. 17 activities fall under the family well-being thematic category, 8 under the community well-being and social capital categories, 5 under the community health policy category, and 3 under healthcare access and quality. So although the obesity life course indicator was grouped with the family well-being thematic category, you can see that activities for one life course metrics indicator can cross-cut several other different categories. For the remaining slides, I'll give a few examples of what the Department of Health is doing to meet the goals of the Healthiest Weight Florida initiative and how they line up with the noted thematic categories. First, under the family well-being thematic category, we are increasing the availability of healthy foods, especially to children. For instance, the Child Care Food Program, After-School Meal Program, and Homeless Children Nutrition Program are 3 great initiatives that provide Florida's children with nutritious meals and snacks. These efforts combined serve more than 197,000 low-income children across Florida. For community well-being, we've partnered with the Pinellas County Parks and Conservation Department to install 9 new outdoor fitness zones in 5 different cities in Pinellas County. Under social capital, the Hernando County Childhood Obesity Task Force has collaborated with many local agencies and businesses to increase awareness of the need to prevent and decrease the rate of childhood obesity in the community. Some activities include the establishment of a local elementary school garden in which produce is prepared in the school cafeteria, and presentations to local educators on childhood obesity prevention as part of their teacher training. For community health policy, our Bureau of Environmental Health coordinates the department's efforts in the area of health and the built environment across the state. We are working closely with the Florida Departments of Transportation and Environmental Protection to increase the number of municipalities, counties, and regions that have complete streets policies. Complete streets policies are designed to enable safe access for all users, including pedestrians, bicyclists, motorists, and transit riders of all ages and abilities. Complete streets makes it easy to cross the street, walk to shops, and bicycle to work. And lastly, under healthcare access and quality, we are assessing clinician practices and documenting body mass indices of patients and creating toolkits to help health professionals counsel patients on weight maintenance. In summary, these are only 5 of many examples of what Florida is doing to address childhood and adult obesity, which has major implications across the lifespan of individuals as well as for families and communities. Efforts such as the ones described exist to promote favorable life course trajectories with the support and existence of key partnerships, investments, and effective evidence-based interventions, not just for obesity, but for other life course metrics indicators as well. This concludes my presentation. I would like to acknowledge the Kellogg Foundation for supporting this project, the National Expert Panel for providing the organizing framework, AMCHP's Tegan Callahan and Carolyn Stanfield, as well as Bill Sappenfield for their guidance and support throughout the entire process. And last but definitely not least, I extend my sincerest thank you to all of Florida's DOH participating staff, Healthy Start Coalition partners, consultants, and volunteers for their invaluable time and contributions in helping to move this process through to its completion. And that also includes Ms. Catherine Howard, who provided a wealth of information on current activities associated with the Healthiest Weight Florida initiative. And with that, I thank you all for your time listening to this talk. Thank you.
Great. Thank you so much, JC. I'm now going to pass it over to Brenda Fink.
Hi, everybody. It's a privilege to be able to participate in this conference with everybody, and as you're hearing, it has been just a pretty amazing experience being able to be part of this for all of us. Each of us learned a lot about each other's states, and yet we were really very much unified and committed to how to do this work in a way that would have meaning for each of us in our roles relative to improving the life outcomes for people in our respective states. For Michigan, we began looking at how to better understand what healthy outcomes and the indicators and metrics that we should be using across the life course prior to this coming up, as many people have. And so what I want to be able to do, the idea of a journey is an often used conceptual framework, but it just seems particularly apt for us because we've been at this now for probably 5 or 6 years of really concentrated effort around trying to really understand how do we begin to work with identifying outcomes in a way that really drives what we do. And early on, we set this set of goals out of the MCH area in public health to say that we wanted to achieve health outcomes that impacted both the quality and duration of life through the following pieces. We wanted to use life course theory. We wanted to maximize every opportunity to improve the impact of social determinants, eliminating disparities, that are based on institutional racism, gender, or class, very much focused on how do we improve community capacity, our understanding of the importance of community. For many of us that have been in this field a long time, we all knew community mattered, that community is where we all live, work, and play. Community is where resources are either available or not available to individuals, and yet beginning to look at that in a way to actually begin to quantify it and qualify it became sort of a new challenge in our minds, and then the whole idea of managing and evaluating a connected system infrastructure became part of that. You don't work in public health with having some sort of pyramid, and we have, there are always a whole variety of pyramids. Everybody has pyramids. Our managed care systems have utilization pyramids and so on. So we kind of began to take this conceptual framework that on the surface is pretty simple, but we managed to make it real complicated real fast. But it was just intended to encapsulate that for whatever outcome we want in the life of an individual, the ability for that individual to achieve that outcome, have a given level of health status, very much depended on the extent to which a community had the resources, capacity, resilience, is prepared to help that individual, and then behind that, what sort of systems support both the community and the individual. We all know that 2 pregnant women that want to have a healthy baby and understand that wholesome nutrition is part of that. One woman may have a car that works in the garage attached to her house and a grocery a half a mile away that has a lot of fresh produce. We also know another pregnant woman with an equally intense desire to be sure her baby has nutrients as it's growing, has no transportation, has no grocery store close by that has fresh fruits and vegetables, and how do we address those things. So what we did is and what's important about these next 3 slides is more the concept of the slide than the detail of what's in the boxes, because you probably can't read what's in the boxes anyway. And we're very much, these next 3 slides are meant to be, like I said, illustrative. Our governor is very invested. He ran on and continues to focus on reinventing Michigan, being the automobile state that's had a particularly rough time. We had to reinvent ourselves over the past years, and he is very focused on the relationship between health, education, and the economy, which has proved very helpful for us in a variety of ways in public health. But basically the concept obviously is a matrix. If you lay out the different periods of the life course across the top, each of us is familiar with that, but then as we began to think how to organize this, then we said there are core health issues, and this is meant to be examples, not inclusive of all of them or the most important or anything, but there are key issues that we have whole people responsible for infant mortality work plans and obesity work plans and so on. So across our activity we have people figuring out what all of this needs to look like, and yet we wanted to juxtapose it with, from an MCH perspective, what are the key outcomes from each period in the life course. We've literally organized our MCH services in an organizational structure that reflects these ways of thinking and so on. So we began defining a project, and in our actual worksheets now are legal size pages literally an inch thick, but we began the process of, Bill showed some of it in his slides, as it was used with this project, but what are MCH block measures and so on, but what are the healthy people, what are the, what is available that lends itself to outcomes from like Bright Futures, that's a healthcare standard. We particularly wanted to weave in HEDIS standards because our department is integrated with behavioral health and Medicaid. Michigan is a managed care state, so our health plans work a lot with the HEDIS measures, so that we would envision from a life course perspective that in theory at least, it's like running a relay race, so that if we want to have an optimal perinatal period, we hand off, if you will, an optimized healthy woman to have a healthy baby. What are the key infant markers to hand off, hand off, hand off? And then if you really do it, it's obviously goes in a cycle. Then we began to identify, all right, if these are the markers of healthy people, how then do we begin to say what the markers, the indicators and metrics need to be? How do we measure what a prepared community is? And so we began to, because like so many of you, over the last several years, always we had community leadership coalitions and so on, but as you begin working on home visitation projects, you work on systems transformation grants from CMS and so on, the need to integrate the system becomes all the more important. This is the crux of where social determinants end up playing. What are the other kinds of resources that exist in a community that are part of quality of life in that community? Then we began to look at the system pieces where we find, and again, this is just a little different way of saying some of the ways the categories were developed in the AMCHP project, but what happens with access? How are community resources linked? What's the strength of medical homes, the data collection and IT infrastructure, policy development, political will? You see some of the same kinds of things. What are measures of that, and so on? So we've been working enormously on very detailed maps that begin to categorize this. Then along came from CMS some of the transformation grants and their conversations about a much more integrated system. We particularly love the notion of the community integrated healthcare system because we were working on something very similar. This was one of our initial models that said if this is the healthcare system and the utilization pyramid laid on its side with your highest need, most expensive folks, you've got the same thing on the community side, but as we all know with the triple aim for healthcare reform, the ability to manage care and costs here is largely dependent on our ability to do the same here and to link the two. And so that, and again, the issue of the social determinants of health and community resources, the role they play in the healthcare system as healthcare reform moves forward and so on. Then when the AMCHP Life Course project came along, we were so excited. We were like all over it, and then Ann in a second just said, we got to get in this, we got to get in this, because we really want to work with other states. This is so important to us as well as then the opportunity to learn from others, and that's been very much the richness of the experience. So our process and the team composition is very like what JC described in Florida. Two people in particular that I want to mention, Patty McCain, who's our MCH chief epidemiologist, has done an amazing job guiding our team with this and doing an enormous amount of work. We also have Julia Haney, who we work in very close cooperation here with Michigan's Public Health Institute, and she has played a very large role in helping our team and our work with this project as well. Both Julia and Patty are very involved then in the process we are doing here, basically housed inside MCH, but as you'll see, we want to really move forward with it in a very expanded way. What we're doing now, as we are in the process of folding in these much more robust and enriched indicators and metrics that have come out of the AMCHP work funded by Kellogg, we're folding them into our very large matrix scenario and set of things. We're in the process where our department consists of, in Michigan, the Department of Community Health is Public Health, Behavioral Health, and the Medicaid State Agency. We are now beginning the process of taking all of this that we've put together to get additional dialogue and input across the rest of our department. We're also beginning the process of a lot of the other key stakeholders in Michigan We work a great deal across departments, child welfare, Department of Education, our early childhood system. We have agreed across departments we need core indicators that all three departments are agreed upon, that social determinants of health must be part of that. And so you see a bit of the list of how we want to improve what we have, as well as use these conversations to really help educate much more broadly this way of thinking about and understanding life course and understanding social determinants of health. Feedback that we have thus far has been extremely positive as we've done these discussions in terms of people seeing the practicality of what we're doing and yet beginning to get how things are connected. And so then as we complete the input process, the intention is to move across, really begin then to use these key outcomes across, the various departmental environments. Currently, this is a list of fairly typical. I think all of us use data, and we want to use this new data in a much more meaningful and targeted way for the kinds of things that all of us tend to use data for. What we're particularly interested in doing moving forward, our governor has a dashboard, and he identified early on he wanted to deal with infant mortality. So we've had, Michigan's infant mortality rate on the dashboard now for several years, and of course, as we all knew, although our number actually is starting to come down a little bit, that marker doesn't move very fast. And we're really now, the governor's office has now asked us what would be some metrics that we could use instead to help inform the population and to track our progress that really points out what is a healthy birth, what is a healthy baby. And so we think that's going to be far more useful. Michigan's doing a state innovations model application. These life course and social determinants this way is being built into that application that will go in. The last three are really part of where we see this really driving policy, program, and practice, is that as we have said and laid out, these are the outcomes that need to take place. You really begin to look at what practices inside our program, what practices are we using, what program models are we using to make this happen? What is the cost of making this happen? The whole issue of ROI that we're all learning how to do. And very importantly, where are our resources being allocated? Do we need to make different resource allocation decisions, not only in terms of addressing the high need populations, but where and how do we have either duplication or gaps or whatever? So this is just an example, a simple one, but we've laid out simply from an MCH perspective. We're doing a lot of work with our behavioral health colleagues to get a far more robust life course mental health and substance abuse continuum, starting with our pregnant women, depressed postpartum moms, to social, emotional, developmental pieces for infants, and so on. But we began to lay out the programs we have according to what parts of the life course do they impact, which of the outcomes and indicators that we're measuring do they impact, and then begin to use this kind of a map to say, what's really impacting what do we need to change, and so on. So that, again, we come back full circle to our original and ongoing aim that was so in keeping with what Bill shared, that was right on track with the AMCHP goal for the project we are just completing and celebrating here today. Which is to eliminate disparities and then use the life course indicators and metrics as core data for a community integrated healthcare system that addresses the social determinants of health. The metrics are intended to support increased community capacity, reflect equity or the lack thereof, and need to drive the system-wide quality improvement infrastructure. So we're very much looking forward to continuing this work, and very much appreciative of the opportunity we have had. And we too express appreciation, as JC did, to AMCHP, Kellogg, all of the people, Bill leading this process, and to our colleagues in all the other states, and the partnerships we all have both inside this phone conference and other avenues where we're sharing with each other amongst the states. So I thank you.
Great. Thank you so much, Brenda, and thank you to all of today's speakers. We really appreciate you taking the time to help us respond directly to our member needs by presenting on this webinar today, and we hope this will generate a lot of interest. Judging by the number of questions being chatted in, we certainly do have a lot of interest. And this is a reminder, if you have a question, please submit it in the chat box. We may not get to all of the questions today, but what we will do is when we post the slides on our website, we'll post a companion document with the questions that were unanswered and then responses from the speakers. Next, I'd just like to invite Amy Zapata to share a few thoughts on what she's heard today and her participation on the Louisiana team.
Thank you so much. First, I would say, at risk for sounding too casual, whoa. Thank you very much, Michigan. I hope maybe we can have a technical assistance call with Michigan. And I was glad to hear that you're 5 to 6 years in with some of your experiences, which is sort of reinforcing to me the amount of time that it does take to build those partnerships and advance a common and shared agenda. And at risk of having a couple more thank yous, I did want to say thank you to AMCHP and to Bill and to AMCHP for having a very interesting, engaging, and iterative process, and that allowed us to examine things from multiple angles. And the reason why I wanted to say that thank you is that I think that there's also a lot to be learned in the process that you all facilitated in the development of the measures, because the solutions are going to require us to be very skilled in being able to navigate and manage those types of iterative, thoughtful processes that keep multi-sectors engaged. And I think some of the other moments of sort of recollection for me during the presentations was, I think another good tool actually were the guiding criteria that we use for considering the measures, because it may be easy to get a little bit too bogged down into to all the different measures that there are. But if you look at the investments that you have, or the investments that we have against those guiding criteria that help to develop the life course metrics, I think that alone is a useful tool for considering where you have current investments of money, time, and energy. And I think the last piece would just be I think that the metrics are very useful in giving us permission to look beyond just the clinical and health to the community and system level factors that help to develop health, and the permission for us to push the envelope and to be having conversations around some of the difficult structural things such as interpersonal and structural institutionalized racism, and understanding what they are. So I think if we look at, in light of the public health impact pyramid and the factors that impact health, along with essential public health functions, that we have another tool in our toolbox to consider how we embrace those. And since these metrics do help us to monitor health status and identify solutions, as well as inform, educate, mobilize community partnerships. And as I was just looking at this right now, just in closing, in terms of the assure competent public health and personal health workforce, I think in some ways we need to really examine ourselves of if we need some new or different skills. If the solutions are going to be cross-agency, cross-sector, into business, into economics, I think that the solutions for us to really come up with those solutions that change the context and address associated economic factors, we need to become more skilled at speaking other languages beyond the most immediate familiar public health. So that's all I wanted to say. Thank you very much for the opportunity. I appreciate it.
Great. Thank you so much, Amy. In the time we have left, we'll turn to the questions that have been submitted throughout the presentations. And as we ask them on your behalf, please do continue to submit questions. I know our time is short, but we will do our best to address questions offline and post the answers on our website. There's one I wanted to address quickly, which was on the AMCHP website. You listed all the metrics, but where are children with special needs? And so I wanted to highlight just quickly, children with special healthcare needs was a critical group considered by the National Expert Panel and the state teams. There are approximately 10 indicators that directly reflect issues facing children with special needs, and this is a group suggested for specific analysis in the indicator narratives being made available throughout the winter. So if you have more questions on that, we're happy to reply by email or to talk with you on the phone. Another question was about the top indicators that we wanted to use but could not due to lack of measurement tools. And I just wanted to point folks to our website. There are 2 documents that address this question. One is a wish list of indicators that we didn't have sufficient data to address. They didn't meet the data criteria, but they're indicators that team participants felt would eventually be valuable additions to a life course indicator set. And the second is a list of indicators that were considered but not selected. And then there's more information in our FAQ document about why some of these indicators were not selected. I'm going to pass the question over to Bill. For Dr. Sappenfield, how did you come up with the 12 topical categories for the indicators? And I'm happy to help you out with that one, Bill.
Carol, I want to just pump that to you. You're doing well.
Thank you. So the topical categories were actually sort of a post hoc way to categorize what had been selected and passed on through to the write-up process. So we had approximately 100 indicators, and what we were trying to do was step away from tagging a specific population group or tagging a specific health condition, but think more broadly about how these topics are related to the life course and how they related to some of the resiliency factors that we were hearing about. So you'll see that most of them are actually phrased in sort of resilient fashion, and we can talk more about it. They're probably not perfect, but we felt like we needed to step away from population groups and health conditions.
We also felt like with 59 of them, we needed to give you some sort of descriptive labels so that you could more easily sift through the indicators to figure out what you're looking for.
Great. I have a question for JC and Brenda. Can you share any information on how you've addressed indicators on the influence of racism on infant mortality?
Hi. JC, do you want to go first? Or this is Brenda.
Well, I have a clarifying question. I'm not sure which indicator that is. I don't recall infant mortality.
I think they're referring to the experiences of racism indicators. There's one for pregnant women, one for in healthcare, and then one for children.
Okay, well, again, we still are in our infant stages of figuring out what to do with the indicators, and we have a few ideas. We've actually done an analysis looking at racism in healthcare settings, perceived racism in healthcare settings in relation to utilization of preventive health services among women of reproductive age. So it's not among pregnant women, but that is just one specific example of what we've done with the racism question, just to get an idea of what's going on in the state of Florida. And we found no significant associations, but we did find other interesting findings in secondary analyses. What we'll do from here on with regards to racism and with respect to those questions, those particular indicators with the life course perspective, that's just something that we'll have to talk about in ongoing discussions with EPI and programmatic staff here at the department, and also look to those narratives that are on the AMCHP website to get further ideas on how we can maximize our efforts to make the most out of our efforts.
And this is Brenda from Michigan. It's not an easy thing to tease through all the pieces, as you well know. But we've also had the advantage of Kellogg funding us for the last several years to look particularly at how we eliminate racism and increase equity in the way we approach the work in Michigan of dealing with our infant mortality disparity issues. They funded us. We call it PRIME, Practices to Reduce Infant Mortality Through Equity. Some of what we've done is, because we have some of these indicators and the kinds of indicators this project chose, they are in fact ones that the point is that you look at what the metrics are for the different races that you have. For us, then, that drives us back to our policy, our resource allocation, our getting cultural competency into what we do. I mean, breastfeeding, safe sleep. We look at not only our African American population with a very particular equity lens, but our Native American as well. I mean, very much how the white culture differs from the African American culture, which differs from the Native American culture in terms of traditions and practices around how babies are put to sleep. And simply learning the kinds of language, it's less about the metric and the indicator than it does seeing the difference and beginning to analyze how do we move the needle. What is it about how we're allocating resources with our Nurse Family Partnership Program, how we give those resources to the communities with the highest African American infant death rates. Patty McCain has done something, with the Kitagawa analysis to help us really fine-tune outreach for those programs in those communities to focus very specifically on those communities' excess death rates, how we look at the messaging and the language we use with different populations in different areas around the breastfeeding and safe sleep. We found safe sleep for many women who live in neighborhoods that are not safe. Their idea of safe sleep, just simply in that name, the most protective thing they could do in a neighborhood of violence, and where literally some of the women have experienced gunshot wounds, gunshots going through their house, was to take the baby to bed with them. That to them meant safe sleep. So it's, for us, we're finding, yes, get these indicators right, but and then how we train our staff, and that was a big focus, and we're still undergoing working with that. But the Kellogg grant is helping us then develop a specific curriculum for training staff around equity issues and addressing racism from an institutional perspective. And that curriculum we hope to eventually make available for spread to other public organizations and state and local health departments and so on. So sorry, that was kind of a long answer.
Thank you, Brenda. No, that was fantastic. Thank you so much. And we know that this is just not enough time to get into all of the meat, but we see a few people are still hanging on. So I think I'm going to pass one more question to Bill. We got a question about, is there a way to score these indicators or some key indicators to come up with a scorecard for states or counties, et cetera?
That's an excellent question. I think we, at this stage, as states, recommended that these not be like performance measures or state measures so that we would be necessarily evaluating states per se, but giving states tools to assess. The idea of, can this be created to an overall indicator, because I know we now see report cards on other health measures and economic measures and business and environment and such. That's a very interesting idea. I'm not sure that we're far enough along to know what that is. I think the closest thing we have to that is our short list. And the idea was 12 indicators is, can we make that short list more visible and put on the state so that you can sort of see where you are. But I like where they're thinking, and gives us food for future work.
Great, thank you. I think we're going to wrap this up since we're about 6 minutes over time. I want to thank all of our presenters for a wonderful discussion, and I'd also like to thank our attendees for being on the call today, and of course the W.K. Kellogg Foundation for their support of this project. We hope you found this information to be value added for your work and that you'll share the information with your colleagues. I'd also like to remind you that the link for the survey will be emailed to you shortly. Please complete the survey and also look for an email next week containing links to the recorded presentation, the speaker slides, and the answers to all of those questions that you chatted in that we didn't have time to address. We look forward to your continued collaboration and partnership as we navigate this topic together. And this concludes our webinar. Have a great rest of the day.